I want to go through some slides with you guys and fairly quickly because I want to leave some time for questions. And essentially what we're going to talk about is we're going to talk about the direct primary care model. And really we're going to talk about why medical students should be really excited about it. You know, I teach medical students here in the office for 3 different medical schools, and it's very common for us to have a medical student that, you know, wanted to go into, you know, anesthesiology or emergency medicine or, you know, cardiology or something like that to finish our rotation and basically say, you know, they're really glad that they did this because now they're pretty sure that they want to go into primary care or family medicine in a direct primary care model. So I'm going to try to take you guys through some of the reasons it's so appealing and why it's, you know, not only a great choice for medical students looking at specialty choices, but also for physicians that are already out in practice. I believe we will have a hand in helping about 500 plus physicians just this year to convert their practice model over to direct primary care. So it's a huge trend. So what are the things that family physicians don't like? These are things that sort of keep them up at night. So concern about a Medicare RAC audit, you guys probably don't even know what that is, but it's essentially where Medicare can come into your practice and they can say, it looks like you might have overcharged Medicare a little bit, and they can shut your practice down without any due process. There's no legal process. They just basically have a company that makes a commission on finding overages. And basically I had a friend of mine who's about an hour from me, and she had 5 guys in black suits show up one day and tell her they were shutting her practice down. No process, no court, nothing. And they started auditing her for Medicare stuff. And that's something physicians are really concerned about. We've had a couple of practices in North Carolina shut down by that. And even when Medicare fraud doesn't exist, it's just because of the process. Confusion about ACO implications. You guys have probably heard of ACOs. The bottom line is an ACO, as it's conceived philosophically, is a good model. The problem is the way that it's been legislated, it's not a good model, and it probably will only work for about 2 years. One thing I hear all the time that I want to make sure that the medical students that are on this call today hear is that when you think about wanting to go out into solo practice and just hang a shingle and be a physician, a lot of people will tell you that's impossible to do these days. And the truth is it's not. In this model, it's very easy to come straight out of residency, open your own practice, start from scratch, and do that. Just last night, I got an email from an investor in a rural part of North Carolina that said they would put up $1 million to start a direct primary care practice in their town. They would pay back all the medical student loans for the medical student and give them a salary guarantee if they would come start a DPC practice in their town. So people are really passionate about the model and what it can do for patient care and also what it can do for patients that are sort of underserved and uninsured. You guys don't really have to worry about ICD-10 now. A lot of physicians are worried about it. You know, SGR is basically, you know, how physicians get paid through Medicare. And these are all issues that in the traditional world are real problems. But none of this stuff DPC docs have to worry about. So, you know, coding encounter forms doesn't matter. You know, whether or not the government decides they're going to pay what they should for primary care or not, it really doesn't matter in this model. I show you this picture for 2 reasons. Number one, it's a good picture of me. But number 2, the title, Keeping It Simple, is very important. So I'm going to try to give you guys an analogy to very simply put into perspective what this is about. So, you know, one of my first jobs was cutting grass, mowing the lawn of my neighbor, and he used to pay me $20 to do that. And it was a simple sort of direct primary care transaction of cutting his grass and getting paid. And what's happened in medical care is, if you take it to the mowing grass analogy, it's like having to pay a friend of mine $10 to send a bill to my neighbor for cutting his grass, and then having to pay somebody else $10 to go and make sure he pays his bill. And by the time I've paid $10 to one person to submit my bill and $10 to somebody else to collect the bill for mowing grass, then the $20 I charged him from cutting grass is gone, and there's nothing left over. And essentially, that's what's happened in primary care, is the overhead of processing claims and the bureaucracy of the office has become more costly than it needs to be, so much so that in many cases it's more costly than what insurances will reimburse. So we've sort of bypassed that. So what are some of the pluses of direct primary care? So first of all, it significantly lowers out-of-pocket costs for most. Quality is improved dramatically, and I'm going to show you guys some slides in a minute with some data from some independent not-for-profit organizations that are going to show you some of that. There's complete price transparency. Patients know exactly what it's going to cost. There's no hidden surprises. There's no secrets. It lowers overhead substantially, helps the practices financially. It also greatly improves access for the uninsured and poor. So the entire reason that I started the model 14 years ago was essentially because I wanted to provide a way for people that didn't have insurance to be able to see a primary care physician. And in our town, at the time, if you wanted to see a primary care physician and didn't have insurance, you actually got charged a higher fee than insurance companies did because they had sort of negotiated a lower rate. And I also, at the time, I saw that physicians were really just running on a treadmill. They were very burned out, and I still wanted to do primary care, but I didn't want to do that type of primary care, so that's the reason for it. The downside is if you're in a practice already, if you're, let's say, you guys will be coming straight out, but if you were in a practice and you had to switch it over to this model, it takes about 6 months. And it's fairly disruptive to the practice. A lot of times, you have to let some staff go because you don't necessarily need somebody to do your billing. You don't need somebody to do your coding. You don't need a lot of the staff that are in some medical offices, so sometimes there's some turnover there. And then the second downside is sort of making patients understand, sort of this idea there's this copay culture out there where people just expect to go to the doctor and pay their copay. And so you have to recruit a patient panel that really understands that they're getting value for their care and that they may come out less expensively out of pocket, but the idea is not just that they sort of pay a copay and let their insurance handle the rest. It's sort of a different model. So I want to make sure you guys understand the differences between concierge and direct primary care. First of all, they do share some similarities. So concierge care does improve quality for patients. When you only see like 7 or 8 patients a day, they get longer amounts of time. Typically, the physicians are less stressed. They get good care. It also improves the physician experience and the physician's pay generally. But concierge practices typically have very small panel sizes. So they might only look after 500 patients. And if all the physicians in the country did concierge, it would make the primary care shortage a lot worse. So direct primary care actually improves access for low-income patients, whereas concierge practices actually make it worse. So one way you can easily tell the difference is if you were to go in the waiting room of a direct primary care practice, you might find a lot of patients that didn't have insurance in the waiting room. You might also find patients in the waiting room that are uninsured. You're very rarely going to find that in a direct primary care or a concierge practice. Most of the patients in a concierge practice are going to be a little more affluent. They're typically going to have more disposable income, and a lot of them are already going to be insured. Another difference is that the workforce is actually improved with direct primary care instead of compromised. So 2 things. Number one, the panel sizes are a little smaller with direct primary care, but they're actually about the size that the Institute of Medicine considers optimal for patient care. And generally they're around 1,200 to 1,500 patients, sort of at a maximum. And that's at least 3 times more patients than a concierge practice would have. Another way to think of it is, most people can afford a Honda, right? Might be a used Honda, but most people can afford one versus a Ferrari. When you think about the average consumer, the average person can't afford a Ferrari. So that's another way to think about the difference between the 2. And DPC can be successful in rural and poor communities, whereas you're not really going to be able to sustain a concierge practice in a rural or underserved community. It also can really lower out-of-pocket costs and downstream costs. And like I said, DPC panel size is really optimal. It's smaller maybe than some practices see now, but it's really sort of the max load that family physicians can really handle and take good care of. So this is a picture from a magazine article, and one of the reasons this is my favorite moment is this is from a day when I looked out in the waiting room. We have a glass window at the front, And I was back in the lab, and I looked out through this glass window, and I saw this fellow right here who's homeless, and he was sitting right next to a millionaire. And the millionaire had driven about 2 hours from Wilmington to come to our practice. And in an instant, what I realized was that both of these patients had access to the same quality of care, even though they were from entirely different backgrounds. And so that's really was one of my most satisfying days when I realized that both of them came here for different reasons. If you ask the homeless guy why he came here, he would basically tell you because it's the only place he could afford. And if you ask the millionaire why in the world he came here, he would say, well, because Dr. Forrest, I can't get care like that at any price where I live. And that's the reason I'm willing to come all the way up here to see you. So let me give you guys a little bit of history, so an overview of sort of how things have developed in DPC. We worked on developing this model back in the late 90s, and we opened the first Access Healthcare clinic in 2002 in Apex, which is where I'm talking to you from today. We actually have facilitated clinics now in 17 states, and we're now working on making 3 islands in Hawaii the 18th state to be involved. Q-Liance, which is a employment-based model. So Q-Liance is a DPC model where the physicians are salaried, is in the Seattle, Washington area, and they evolved from Concierge. So their founder initially was a concierge physician in one of the first concierge practices in the country, and he decided he was going to make it a little more affordable, so he basically decreased the fees, and that's sort of where they came from. But they're mainly, I think they have 5 clinics there, but they've been responsible for doing a lot of the good lobbying efforts and a lot of the political advocacy for the model nationally, even though they're just in Washington State. And Medline opened their first office in 2009. They had 4 clinics now. They also came from Concierge. Now, when you guys wonder about what is a concierge practice really like, well, the founder of Medline told me that when he was doing concierge practice, he charged each patient $30,000 a month to be his patient. And obviously that's not affordable for almost anyone. His practice was based in the sort of Beverly Hills type area, and so literally, you know, if one of his patients wanted to see if their sunburn was getting severe, he'd walk out there and look at it. But, you know, they were paying him $30,000 a month. But essentially he also decided that the fee was too high. His wife, who's also a medical provider, got out of her training, and they wanted to do something a little cheaper. So that's sort of where Medline came from. Access Rhode Island started a statewide network in Rhode Island back in 2008. And it's a hybrid network, meaning that those practices still take insurance. In fact, they mostly still take insurance. But they have availability to do DPC for people who are uninsured or people who have high deductibles. And the cool thing about it is people can actually like buy these plans and search for the plans on a centralized website in Rhode Island and contract with the network basically to find care. So I think they have about 35 physicians there now. AMG Medical opened in 2011. They're actually in downtown New York in Manhattan. They've got 6 very successful clinics there now. Iora Health opened in 2013. The foundation was laid back in 2007 with Renaissance Health by Rushika Fernandopoul, and they also have a DPC component now. Paladina is interesting because they opened their first clinic in 2012, and they were actually started by DaVita Dialysis. And DaVita Dialysis actually came and consulted with us about 4 years ago and said they wanted to look into opening DPC clinics. And so we helped them out with that, and now they're one of the biggest DPC employers in the country. Atlas MD opened in 2012. They're out in Wichita, Kansas. And they've been really known because they've gotten a lot of publicity. They're Doug, who's one of the docs there, and Josh, it seems like they're always on TV or radio or something talking about the model. So they've been really good for sort of getting the word out and making people aware of DPC. And then in 2012 to 2014, you literally have had hundreds and hundreds of DPC clinics opening. I would guess probably it averages about 1 to 2 clinics per day around the country. And the common feature is that they all have options for patients, that cost similar to like the cheapest individual cell phone plan you could get. So, you know, if you went to Walmart and you found the cheapest cell phone plan you could buy, that probably is about the same as what most of these practices are charging. And either the patient pays that monthly fee, sometimes employers will pay the monthly fee for their employees, but there's no insurance claims filed at all. So what did people think when I was a medical student and resident and said I was going to do this? They thought I was an absolute nut. I remember my residency director, who had sort of a great job lined up for me at Duke, saying it was just insane for me to do that and not take insurance, and he never heard of somebody doing that. So it was sort of a different idea. That's why we opened on April Fool's Day. Many of you may know another company that opened on April Fool's Day because people said there'd never be a personal computer in every household. That was Apple. So they've done all right. So I figure we're going to do all right too, since we opened on April Fool's Day as well. This is probably the most important slide for you guys to look at in terms of understanding how the math works. This is really as simple as it is. If you look on the left-hand side, what you see is that most practices only collect 65% of what they charge, and then the overhead in a traditional primary care practice is 60%. So what happens is, if you charge a patient $1, you're only left with 26 cents. In our model, if you charge a patient $1, you're left with 81 cents. So that's over 3 times as much, and that's assuming you're charging them the same thing and not giving them a discount. So this is really what makes it work, is getting rid of the overhead and getting rid of the waste and making sure your collections are high. So our overhead last year was about 18%, which means we have a lot less staff than most offices, because we don't need any staff that are devoted to filing insurance or anything like that. So the main staff person that I hired that works with me has been working with me ever since we opened 13 years ago. So she's done a great job and has sort of grown with the practice. And essentially we have one person like that for every physician. So it's sort of one physician, and then there's one person that sort of provides the staff support. So a summary of the model for us: we charge about 80% less. This really helps access for the underinsured. We do have higher collections, and we spend a lot more time with patients. This is one of the things that really makes it work well. We don't file any insurance, so I haven't taken insurance from anybody in 13 plus years. Now here's the cool part. You know, you guys always hear about medical malpractice and how high the rates are. And our malpractice company actually gives us 65% off for practicing this model. So my medical malpractice bill is about 2/3 less than what it used to be when I first opened, when they found out about this model. So they realize it's lower risk to get sued. You know, when you can spend 30 to 45 minutes with every patient instead of having to see a patient every 8 minutes, it just makes a lot of sense. And, you know, you guys hear a lot about sort of being a medical home or a patient-centered medical home. And really, to really be a medical home, you have to have some time to coordinate care. You can't just delegate all of the things that patients need to other people. There are some things you can delegate, but, you know, you really need to be there yourself. And we're going to get into more of the face-to-face time in a second, so you guys will see the difference. The idea of the genius of the gym is that if you think about it, if you went to a gym and they had somebody follow you around and sort of write down when you lifted a 5-pound dumbbell or a 3-pound dumbbell, and then when you got on the treadmill, they had to write that down, and when you got on the elliptical, they had to write that down, it would cost so much to pay that person to follow you around the gym that it would be more expensive than your gym membership for the whole month. But that's the insanity of what we've done in primary care. So really what it is, this is like a gym membership for healthcare. So, you know, we charge you a monthly fee, and you use the services that we have, and we take care of you for that membership fee. This is a picture to show you, number one, I can be fairly flexible sometimes, but also to show you that it's important to get the payers out of the exam room. A lot of physicians sometimes feel like the insurance company is sitting on their shoulder and telling them, you know, they have to prescribe a certain medicine, or they have to refer to a certain place, or they have to send people to a certain hospital, and the physician may not feel like that's the best thing for the patient. And what's nice is, without having any conflicts of interest or contracts with insurers, I can really do what I feel like is right for the patient. The 550 paradox, we talked about this a little bit earlier, but you know, a lot of times people would say to me, well, Dr. Forrest, you do a great job for the uninsured, but what about Medicaid patients? So I didn't think I had any Medicaid patients. Then I actually went down and got some data and found out that the physician who had asked me that, I was actually seeing 3 times more Medicaid patients than he was. And when you look in the practice at insured patients, it's about 52%. And you'd say, well, you know, why would people come to your office and not use their insurance? Well, you know, it's the difference between spending 50 minutes in the waiting room and 5 minutes with your doctor, or spending 5 minutes in the waiting room and 50 minutes with your doctor. And a lot of people are willing to sort of go for a different model to have that kind of difference in access. I'm going to go through here. We kind of talked about FTEs, or full-time equivalents. So just so you guys know, that means there's 4 less staff people per physician than in most practices. What about the quality? What about the results? Well, they're outstanding. So we've had several not-for-profits and 2 universities follow the data, not just for our practice, but also for other physicians using the model. So I'm going to try to scroll through that real quick because I want you guys to have some time to ask questions. The quadruple aim, the idea is better quality, improved access, lower cost, and a better physician-patient relationship. So this is a study done by the MBA program at North Carolina State University. They finished it up last year, and you know, completely unbiased. These guys came in, they had full access to our data, and I'm going to show you some of their results. So nationally, the control rate for blood pressure of patients being seen for blood pressure is only 50%. And the students found that for these 3 DPC practices, it was actually about 80%. That's a huge difference. And that's the kind of difference that actually prevents stroke, prevents heart attacks, and that can save a lot of sort of downstream costs. COSEC, which is a not-for-profit out of Winston-Salem, Lake Forest, did a comparison on the left of traditional PCMH practices, hybrid practices in DPC, and found that systolic blood pressure control, LDL cholesterol, and HDL cholesterol were all controlled better in a DPC model. When you look at improvement percentage, that was also better, because some people would say, well, your patients must have just been healthier from the beginning. Well, no, we actually had better improvements in all these patients from baseline than the other practices did as well. Now, this is a slide you guys may see from some other presentation. It shows the cost of medical care in all these different countries. And what I want you to notice is the United States, first of all, is about twice as much as every other country. And what the MBA students did, which was kind of cool, is they graphed out, they basically took all the payments from our patients for the last 10 years, all of their costs, insurance costs, out-of-pocket costs, everything, and then they graphed us out. And what you can see is this model for these patients is cheaper than every other country, and it's also a fairly flat slope. So, again, some people said, well, your practice must be different. You must have a lot healthier patients. So the NC State students looked to see if that was true, and what they found was, no, you know, our patients were just as sick as everybody else. They had similar diagnosis codes as other practices, and the only difference really with our patient population was that we had a higher proportion of uninsured patients. So this compares the patient experience, and this is one of the more important things for you guys to see. Number one, we'll start at the bottom. You can see that hospitalizations are about 60 to 65% less in this model. You can also, if you look at the graph over on the right and look at face time per visit, it's significantly different. And if you look at total doctor time per year, and I think this is really what's telling, is that we have 140 minutes of face time with a patient per year versus only 20 minutes in a traditional practice. And if you're trying to get somebody to quit smoking or eat better or understand how to take their medications or understand how to use their insulin properly, you just can't do that in 20 minutes in a year. But you can definitely get it done in 140 minutes a year. So these are some of the key problems the model solves: practice viability, physician burnout, workforce recruitment. This is you guys. So let me just say this real quick, because I think this is important for you guys to know. In this model, if you have 1,200 patients, which again is very manageable. Most family physicians these days have about 2,000 patients. So here's those income expectations. So you really ought to be able to do similar to cardiology or GI. You ought to be able to do better than general surgery and also better than most of the other internal medicine subspecialties as a DPC physician doing primary care. Now, that can be family medicine, or it could be internal medicine, or it could be pediatrics, any of those. So this is what one medical student said about the practice, and this is an excerpt from a longer piece that was on Kevin MD and Primary Care Progress by Brian Lanier. And it talks about sort of, and that piece, you guys should all go read that, but this is just one little sample of it. And it really shows how he felt about direct primary care once he had experienced it for his rotation. And it gives you an idea. And he says at the bottom, you know, I will be able to provide the majority of care for my patients that they require instead of having time only for refills and referrals. In short, I will be part of the solution both for my patients and for the system as a whole. So medical students that have experienced this are really passionate about it. The AAFP, the American Academy of Family Physicians, now is in support of the model. They actually say the model emphasizes and prioritizes the physician-patient relationship and is in line with their goals of patient-centeredness. Significance, the ACA has a little paragraph in there that says this can be approved as a type of qualified insurance plan when coupled with a catastrophic plan, which is really cool because that means people wouldn't necessarily have to pay the penalty if they didn't go out and buy a traditional insurance plan. Satisfaction's better, and this thing is growing exponentially. If you look at what this Medscape article said, it said that 30 to 40% of all independent physicians will be doing this model in 2016. We've had lots and lots of meetings around the country, and I just got back recently from Hawaii and also Maine. I just enrolled 23 practices in the network from Maine that all want to convert. And if you look at large companies like Expedia, Whole Foods, all these companies are interested in doing this as sort of their healthcare model because patients love it and it's less expensive. I'm on the board of directors with the chairman of the board for Whole Foods, and they've already started doing some pilots with this, and Whole Foods likes it because it's less expensive, but their employees love it because it's actually a lot better care, and they really enjoy the model. This is just to show you guys a quick footprint of all of our practices around the country. This is what the little membership cards that patients have on their keychain, which is very similar to like a grocery store type tag. They come in, they swipe this at the window, and we know that everything's up to date. This can track them. It also can keep up with certain types of data between practices in our network, even if the practices have different EMRs, so it sort of solved that compatibility problem. And here's some references for you guys if you have more things that you want to learn about DPC. I'll just tell you that the Twitter feed at the bottom, I pretty much give about 1 or 2 DPC updates on that Twitter feed every week. I just started using that really this year, but if you're interested, that's a place I'll constantly be giving some feedback. If you go to that Newsly site that's down at the bottom, it's got about 20 articles or more about the practice model, and is a good place to find out more information as well. So I'm going to stop there. I know it's been at record speed, but I wanted to get all that in for you guys and let you guys ask questions.
Hi, everybody. So this is Jenna, the primary care coordinator. First off, thank you so much, Dr. Forrest, for joining us and talking about DPC.
You're welcome.
I'm gonna go ahead and unmute everybody else in case anybody has questions.
Okay.
I think Daniel is the only person that's connected to audio right now.
Okay.
Hi, Dr. Forrest. This is Dan.
Hey,
Can
how
you
are
hear
you?
me? Good. How are you?
Good.
Thanks for your talk. Really interesting model.
Thank you.
I was curious, how does your model usually work with patients who need access, like referrals to specialists or with hospital admissions? You talked a little bit about briefly about high deductible health plans as something that works well with your model, but how has it worked in your experience?
So that's a good question. A couple of issues there. Number one, remember, this model is about primary care, so it pretty much fixes the primary care portion. Now, having said that, I've run into exactly what you're talking about. I had a patient once who, she came for her physical, and she's like, this is great, you know, I can afford my physical with you, She's like, but I'm not going to be able to pay for my mammogram because she said the radiologist around the corner is going to charge me $450 for a mammogram. So to make a real long story short, basically we got that radiologist to do mammograms for our patients for $80. And so she could just take her little card down there like you saw. She could show it to the radiologist, and he would give her a discount and make her mammogram $80. And we've got similar discounts worked out for specialists. We've also got some discounts worked out at hospitals. The problem with hospitals, though, is hospital costs get so high so fast that it's still going to be more than most people can afford out of pocket. So, you know, that's why we encourage people to have some type of wraparound coverage, to have some type of health plan. You know, a lot of our patients actually have the ACA Bronze plan, which is a higher deductible, you know, insurance plan that's affordable for most of them. So, you know, if you're going to have to go in the hospital, then you're going to need insurance to pay for it. But for the specialist, I'll just give you another example. A cardiologist who might bill Medicare $2,000 for a stress echocardiogram, he'll do it for our patients for $200. So that's 90% off. Now, here's the really cool part. Let's say it was a Medicare patient. A Medicare patient normally would have to pay 20% of their bill. So 20% of $2,000 is $400. So by going around Medicare and just using our discount card, it actually saves them $200 out of pocket not to use their insurance.
Yeah, that's really neat. Another question I had was, so is it a flat subscription, like monthly subscription fee that's your charge to your patient?
Yes, so there's several ways they can do it. They can do like an annual fee, they can do a monthly fee, or we do have people that are just, you know, like maybe they're 25 years old and super healthy and they just want to occasionally come in for a runny nose or something, and those people can pay a la carte if they want to, and we've got sort of those type prices pasted out in the waiting room on a board so everybody can see them. So if somebody just walked in and they you know, were young and healthy and they didn't want to be a member and they weren't going to need refills of things and they just needed to be treated one time, they could do it off of a la carte menu.
Very nice. How does your practice still make a profit when, say, you have someone who signed up for either the annual or the monthly plan, and you know they have like multiple medical issues and have, you know, kind of like quite a few visits per year? How do you keep a profit on those patients?
Yeah, that's a great question. So first of all, one of the important things to understand about doing this model correctly is you have to set it up so if a patient was to come in every single day, let's say a patient came in 365 days a year, you still would not lose money. And the reason for that is that their monthly fee is also accompanied by a very low per visit fee. So our patients, when they come in, they pay a low nominal fee every time they contact the office. And that
I see. That makes a lot of sense.
It does two things. The fee is really low, but it's enough to cover our overhead costs. And the fee also, because it's there, it keeps them from coming in too often. You know, if it was totally free all the time, then you'd have a few patients that might come in too much. But by having it be a very low fee, and I mean it's really low, it's much lower than most people's copays are. That keeps people from overutilizing. We also know, after looking at it for 13 years, that 90% of the patients aren't going to come in over 4 times a year, even with a membership. So statistics are sort of on our side that we've never had anybody come in, I think, over 12 times in a year.
Gotcha.
So I think Rachel saw some questions in the chat that I didn't see. Rachel, would you like to ask those questions for those people?
Yeah, let me just make sure. There was a question that was asking more specifically about the transition, Dr. Forrest, that you talked about. So for clinics that are currently not DPC model-based, are there step-by-step protocol resources on how to implement the transition?
So you're talking about practices where they're already taking insurance and that kind of thing, and they want to switch over. So
yeah,
there are some resources because I guess back in about 2007, I started getting a lot of calls from people who wanted help with exactly that. We've sort of developed a team that can help practices like that. So, for example, we've got 3 lawyers we work with. We've got 2 MBAs we work with. We've got a vendor that takes care of all the membership management software and processes all the monthly fees and everything else. So everything you can think of, the telemedicine component, our physicians can talk to patients over their iPhone if they want to, just like FaceTime, even if it's not a Wi-Fi network. And, there's all sorts of resources that we provide to people who are trying to transition, basically to make this as turnkey as possible. So, like I said, this year we're working with over 500 physicians. I got asked to go to Hawaii and speak to the University of Hawaii about this, which, you guys can cry a big tear for me. That was about a month ago. And after we gave our presentation, we had 7 physicians ask us back to come and transition their practices. And 2 of those were on Oahu, and 2 were on Kauai, and 3 were on the Big Island. So, practices are really interested in transitioning. It is somewhat of a process, but it only takes about 6 months. So there's a physician who's actually opening today in the eastern part of our state who had heard me give a presentation while he was still in residency, but he had already signed an employment contract. So he went out into residency, and after residency, he went out and he worked for this hospital for 3 years, and he just got so burned out. So he called me up about 8 months ago and said, hey, I still want to do that model you talked about several years ago. Can you help me transition? And so today's the first day he's open sort of doing that new model. So, even for people that have sort of started out in the traditional role, it's doable. And I've also helped several people straight out of residency. There's a guy in Asheville. He finished up his family medicine residency, and we helped him straight out of residency. He's been open 3 years now, and he's got 3 physicians in his practice. And he just took his wife to Europe for a month, so I think things are going good for him.
Well, great. Yeah, thank you so much. Our second question that we had was, again, sort of about this transition, but more specifically about the staff experience. So from your experience, what kind of staff, clinical or administrative changes would one potentially see in such a transition?
So usually any of the staff who were not involved in patient care at all, they're not necessary anymore, because you don't have people submitting bills, you don't have people sort of filing claims, you don't have people coding encounters. So the only people you have are pretty much people to check in and check out the patients, people to answer the phone, people to set up strep test and urine analysis and EKGs and things like that. And those people can handle 15 people per day each. So you really only need one person to do those kind of responsibilities in addition to the physician.
Great. Well, thank you so much.
All right, so I don't see any other questions. If anybody else has any, feel free to send them to us in the chat or to connect to your audio. I'm going to go ahead and stop the recording now. So thank you so much again to everybody who has joined us, and especially to Dr. Forrest.
Oh, you guys are welcome.